यस नरेंद्र जी कैसे हैं? हेलो,
Yes, sir.
हाउ आर यू?
Sir, good. I am fine, sir. Thank you so much. I am fine. How are you, sir?
आई एम ऑल राइट, फर्स्ट क्लास। आप बताओ नया क्या है, ये बताइए। रेमडेसिविर कौन कौन ला रहा है?
हाँ जी सर।
रेमडेसिविर कौन कौन ला रहा है?
अच्छा, रेमडेसिविर नहीं नहीं, अभी अभी तो कुछ मालूम नहीं पड़ा है सर, बट इतना आज मैंने न्यूज़पेपर में पढ़ा कि इट हैज बीन नाउ मेड अवेलेबल टू ऑल, so that is just on cards.
नो, आई
There is
थिंक
no plan we have made so far.
आप लोगों को many companies are coming with remdesivir. You have no choice. Every company must bring it.
Yes sir, yes sir. Many companies must be launching, sir.
So आप लोग नहीं ला रहे?
सर अभी तक पता नहीं है सर, because that is a different division.
I know, but then
मेडिसिन को, हाँ, एंटीवायरल का जी।
hmm.
But no, we have not decided as anything as of now.
As of now.
Okay.
So what is your number one molecule today where you want to concentrate?
Sir, we are concentrating. I mean, sir, today now situation is also changed. Sir, ticagrelor is one we are focusing on. Sir, all
Which
these
one?
Patex molecule, ticagrelor, ticagrelor. Sir, all these Patex molecules which are coming, so they have got the maximum potential because there is nothing new to launch, and we are left with only choice of either launching a Patex molecule or launching a new combination of drugs, that is fixed dose combination, or something like, something technologically different, like a new dosage form or something like that. So out of all these three, the most best is this Patex molecules. So we have vildagliptin, which we have launched. We have ticagrelor that we have launched. We have remogliflozin that we have launched. So, and upcoming Patex molecules also, which are coming, every 2-3 years, there will be molecules coming in. So in diabetes and cardiology, as well as other specialties also, we will be continue to launching these molecules. So that is the most lucrative as of now.
Okay.
Yes, sir. So thank you so much for organizing everything.
No. I'm now for the last 3 months doing and moderating practically 4 to 5 sessions every day.
Every day, 4 to 5, sir. That's the number. Oh, okay.
I'm doing because in COVID I am well versed.
Yes, sir.
And so I'm doing it for nurses separately.
You are sending me 3 mails every day on COVID, sir.
So I'm doing it for nurses separately, pharmacists separately, NGOs separately, public separately, policymakers separately, doctors separately. So everybody is in fear. So they are very dumb. So tomorrow I'm talking to all the traders associations in the country. Then I'm talking to RWAs in the country, all resident welfare associations, what they should do. Then Thursday I'll be doing it with approximately 2,000 school principals. And we are discussing about opening of school. Then we're discussing with this a separate session with college principals. And so that way my sessions are starting from every segment of the society. And we are basically, then every day for 1 hour, 3 to 4, for the last 60 days, today was 60th hour, I'm discussing on Vedic philosophy, Vedas and COVID. Because people
Vedas and COVID.
All Vedas, every Upanishad I take and say how messages are there to control diseases like COVID. So today we talk about, say tomorrow I'll be talking about Prashana Upanishad, so like that. So I pick up every Upanishad one day. So we finished Ramayana, we finished Hanuman Chalisa. So
how do we get links for these? You are sending links to people?
I have a fixed audience because the 3 to 4 seminar is approximately attended by approximately on an average by 1 million people every day. That is a different type of a group who wants to listen to it. It's more like a discourse, like a discussion, which I do every day. And these are on various forms. And so tomorrow I'll be discussing in great detail about prana. Prana means our breath control.
Energy.
Happening is COVID is One thing phenomena is occurring in COVID, which will come for discussion today also. कि लोगों का सांस में people have low oxygen, but they retain their consciousness.
Okay, so that is happening with COVID patients, sir.
So in COVID patients, we are seeing a typical phenomena कि आदमी का oxygen low है, but brain normal, means he is not confused.
Okay.
So how do we explain? Modern medicine has no answer.
No answer, sir. No answer.
This answer comes from Ved. वेदों में clear लिखा हुआ है description कि ये कैसे हो सकता है. क्यों हो सकता है वो नहीं लिखा, वो still dilemma में है. But what is that phenomena which can happen is written in Ved. So tomorrow my whole discussion will be on breathing as discussed by, say, death, description of a death, description of a birth. ये सब जो वेदों में है वो हमारी modern medicine में नहीं है.
नहीं है सर.
So
काफी जी.
So there is.
हम मुझे भी include कर लीजिए सर.
Dr. Wagnu आ गए हैं इसके साथ में. Yes,
Dr.
Wagnu, how are you?
Good. सर टाइम पर हैं एकदम बिल्कुल हम.
Yes.
आपके जैसे.
I will start exactly in time. We will start in time. As soon as Dr. Praveen Chandra comes, we'll start. Dr. V. Mohan may be joining after a couple of minutes.
No issues.
But we will start the program. So we were discussing the inward journey. Dr. Vanu, Mr. Narendra Choksi, we were discussing about the journey inside within us. That COVID has directed us कि बाहर की जर्नी बहुत हो गई. Now go back within purpose of your life. आप पैदा क्यों हुए थे? आप कार्डियोलॉजिस्ट क्यों बने? आप डायबिटोलॉजिस्ट क्यों बने?
बिल्कुल सर.
Sir, the situation is going to be very grim in coming months. I can predict it, and the major burden will be faced by the healthcare workers when the cases will become close to US in the end of July or beginning of August.
Absolutely.
And we are facing this self-inflicted refugee crisis also. How many migrant workers? And you know, yesterday in UP, one of the villages, the returning migrants, 50 of them were found to be positive.
How many?
Yeah, COVID is small village. 50 migrant returnees, and yesterday they were found to be COVID positive.
After how many?
Huh?
Of how many?
I don't know how many, but 50 of them were found to be positive in one small village, a particular village.
See, 8% are found positive amongst all the migrants who reached Bihar. 26% were from Delhi, and average from all over India, it was 8%. So we expect that all migrants of 5 crore migrants who are going, 5% of them to 8% of them will be positive. So
very high.
Our number is likely to cross 5 lakhs if after all these migrants, if they are tested. So 99% you will not find them tested. They will do random survey and take care of it.
Dr.
Agrawal.
Yes.
Sir, I just want to confirm that I will be giving a small thanks speech at the end of the program.
End of the program or the start?
No, sir. End of the program. Thanks speech only.
No problem.
Right, sir.
So you have some slides, Dr. Wagnu?
Yeah, your group has sent me some slides. I'll be showing those slides. They're beautiful slides.
You have the slide share. You know how to use it?
Yeah, I know how to use a share slide. How to share the slides.
Yes. So we'll start with Praveen and then Dr. V. Mohan and then you.
Right, sir.
So we are already live, so we can have chit chat before we, as soon as we start sharp at 6.
One question to Professor Agarwal.
Yes.
Was there any need for such an early lockdown?
So there are two issues. One is that if they wanted to do a proper lockdown, it should have been done on 30th of January when the international health emergency was declared. And we had the first case on 31st of January. The very fact we waited for February and we waited for March, that means 22nd of March. So our purpose of lockdown was not to check the progression of the disease. Our purpose was to delay the peak and delay the number of cases so that people can learn out of it. And
are we prepared to just face that delay in the peak? Are we prepared to face that?
No, one can debate that whether the second or the third lockdown was required or not, because second, third, and fourth one can debate. One can also debate that we should have started the fourth first, then second, then first. We should have gone initially, instead of a strict lockdown, we should have gone the reverse way. We could have gone gradually into the first lockdown. That's what it is. Now, this problem now we are facing is because of the migrant population, which government was not prepared. At this moment, two problems are facing the government. One is the problem of migrant, and second is interstate politics. Now because health is a state subject, so interstate politics is causing more harm than good. So therefore, everybody now will suppress the number. Everybody will try to say my state is better. They are not going to come back with the real numbers. That problem we are going to face.
I don't know whether medical fraternity should come out open and just tell all these bureaucrats, government officers, politicians.
I speak every day. I'm very clear. I'm not a political man. I speak what the truth is, what I feel like a truth. I speak it in every forum.
That message should go to them, because the persons who are guiding them behind the curtain, what they have to speak.
Unfortunately, the spokesman of any pandemic is supposed to be NCDC and DGHS. Both of them are in the background.
Okay.
So our minister also is a doctor, but he is not addressing the medical fraternity. He should have been answering the queries of the medical fraternity.
Yes.
Non-medical man is answering the fraternity as a public's face. So all three people who are doctors are in the background, because if I want to ask a question, I can't ask a question to a non-medical man. I must ask to a medical man who is on the helm of affair. That has to be DGHS, or that has to be NCDC chairman, director. Both of them are not a spokesman. We can't approach them. We can't talk to them. So everybody is confused what is happening. And the educated man will not talk a question to a non-medical man, because he will be feeding what he has been told to read out.
Right.
So that is expected out of it.
But
government is doing a good job, what they can do to the maximum. So government is doing a good job. Now nothing is, government can't come to my home and ask me to maintain a 6 feet distance. Government can come back and say wear mask. So it is now my protection. I have to protect myself.
All right. But still, my gut feeling is that the number of healthcare workers getting positive COVID is going to increase in a very exponential manner. What is your opinion?
Agreed, absolutely. It has to. The reason being, one of the learning which the government hasn't done is AII rooms. And in the last 2 months, we should have made airborne isolation infection rooms to a large number. South Korea did it in 5 days. And with that, we are going to have a problem.
We don't have facilities to do that, or we are just not doing that?
Not doing that. AII rooms, negative pressure rooms, if you don't have, you're going to transmit the infection. Remember, the social distancing in a healthcare setting is 13 feet, not 6 feet.
So only ICUs are equipped with a negative pressure? areas.
All triage. See, the triage has to be negative pressure.
Triage.
Triage. That means you the first see the two things are required to check the transmission in a hospital. A patient enters the emergency room. That emergency room is a negative pressure room, and then you the report is available within 3 hours, and then you decide where to shift him. If you don't do that, see what is happening here is the report is waiting for 2 days. In 2 days, you are transmitting the infection.
But how can we get the report in 3 hours, which we don't have
All over the world, report is in 3 hours.
Are they using the different kits what we are using?
No numbers, because there are number of laboratories. You have a laboratory in every hospital in China, in Singapore, everywhere.
Oh.
Every hospital has their own machine. They do it. So we have Dr. Praveen Chandra also joining us, and I think we are going to start in time. Time kitna hua, Nilesh? So we are sharp in time, and
Hi, Dr. Praveen.
Hello, how are you?
I'm good, sir.
Good, very good. So, I think we are before time or what?
So we are in time.
we are sharp in time, so I'll start. So hello everybody, greetings from IGCP Group, MedTalks, and our knowledge partner, Torrent Pharmaceuticals. I have with me Dr. Praveen Chandra, the chairperson of Division of Interventional Cardiology, Medanta Heart Institute at Gurgaon. I have with me Dr. S.K. Wagnu, who is a senior consultant endocrinology and diabetes, Apollo Center for Obesity, Diabetes, Endocrinology at Apollo Hospital, New Delhi. And Dr. V. Mohan, the chairman and chief diabetologist, Dr. Mohan's Diabetes Specialty Center in Madras, Diabetes Research Foundation, Chennai, will also be joining with us. Both Dr. V. Mohan and Dr. Praveen Chandra are Padma awardees. And I also have with me Narendra Choksi, who will be speaking at the end and summing up the seminar. So the purpose of this seminar in the COVID era, at a time when the fourth lockdown is taking place, and the number of cases are still rising. And when the number of cases are still rising, we still haven't seen the peak. We have epicenters in Delhi, Maharashtra, Tamil Nadu, and Gujarat. And we know with the New York experience that unless 20% of the population gets infected, the epicenter will not stop. It will not go into the regression. The statistics shows as on today, our infection rate is from 10 to 13, 14%. The first state to start showing regression will be Mumbai, second will be Delhi, and third will be between Gujarat and Tamil Nadu. We will show these patterns over a period of time. Because the peak is yet to come, and in India, we still don't have the facility for a test being available within 3 hours. We still don't have a facility of a AII, which is airborne infection isolation rooms in the triage in the emergency room. So we do expect in the next 1 to 2 months, large number of healthcare workers showing COVID symptoms. We have lost one of a very senior pulmonologist 3 days back in Delhi. At the age of 78, he was still practicing. He went to the office, he got an episode of diarrhea, he got himself tested positive, he got himself isolated in the room, and he passed with an acute MI peacefully in the night at home. We have another patient, a very senior doctor, surgeon in UP, who was a surgeon who had abdomen, who operated, and after that he felt unwell. Within a matter of 72 hours, he went into a cytokine storm and we lost him. We had cases, initial death of a doctor which occurred in Indore, and we had a death in Tamil Nadu. In total, we have between 10 to 20 deaths amongst medical professionals. Charity begins at home. we want to focus our discussion today is preventing deaths amongst the medical professionals. Whatever we prevent ourselves, somebody was talking to me that my first responsibility is patient safety. But there was a debate in the WMA Geneva Declaration, and there this time the doctor's health was added as a prime importance. If I protect myself from corona, automatically I prevent my patients, because I need much more precautions to be taken than the patient. And if I protect myself, I know how to take care of my patient. If I am diabetic, if I take care of myself, I know how to take care of my patients. And if I am having a hypertension, if I am at risk of coronary artery disease, I know what to expect from my patients, and I know how to protect my patients. These will be our discussion points. I welcome Padma Awardee Dr. V. Mohan also, who has joined us. With that, I will start with Dr. Praveen Chandra, and we will talk about in Dr. Praveen Chandra. In the COVID era, we have various types of manifestations. The first manifestation is this COVID virus presents like a virus. So therefore, drugs like remdesivir are important. This virus behaves like a bacteria. So for drugs like doxycycline, azithromycin are used. This virus behaves like hyperimmunoinflammation, causes high ESR, high CRP. It is causing Kawasaki disease in the children. Therefore, drugs like hydroxychloroquine may have a value into this. This drug is also causing thromboinflammation with a rise in D-dimer and fibrinogen. Therefore, these patients may require anticoagulation or antiplatelet drugs. This is also causing a walking dead phenomena, where the patient is conscious, but his level of oxygenation is 60 and 70. That means these patients need more oxygen. It is also causing cytokine crisis. That means a stiff lung with low oxygenation, requiring these patients, they require ventilator. And this drug is also causing a HIV-like phenomena, causing lymphopenia and causing the damage to the CD4 cells. Therefore, some anti-HIV drugs may also be useful. Dr. Praveen Chandra is going to focus on one of the complications of this condition is microvascular and macrovascular thrombosis. Dr. Praveen Chandra.
Thank you, Dr. Agarwal. And we are, at this stage, we are discussing a lot of the issues related with COVID and a lot of issues related of doctors with COVID. And that is what the main intention of discussion today is. And I thank Dr. KK for organizing this very important symposium. And I thank my colleagues, Dr. Wangnu and Dr. Mohan, who are also here from their very, very busy schedules. So I'm glad that we are, at this platform today to discuss these important issues. So today, what I'm going to share with you is what is the relationship of COVID with thrombotic events? How does it present in terms of thrombosis? Because most of us know that it leads to fever, cough, dyspnea, and respiratory symptoms. But we have now realized and seen from the various series which are available from China, from Italy, and from United States, that it also presents in myriad forms, in different forms. And it can mimic different diseases. It can mimic a heart attack, it can mimic a stroke, and things like that. So I'll go through that. But before I really go for the thrombosis thing, I will share with you the protection, because Dr. KK told me that we also want to discuss the protection which we have to do in these patients. And I'll take you through that. I think it is in the end. Okay. So what I will share with you now is that with COVID patients, 80% of these patients remain all right, and everybody knows this now. It's a known fact. But some patients become very sick, and the sickness is mainly related to the respiratory respiratory system and also sometimes beyond the respiratory system, where these patients come with acute shock, multiple organ dysfunction, and sometimes also presenting and mimicking the coagulopathies, systemic coagulopathies such as DIC, thrombotic microangiopathy, and also sometimes myocardial infarction and stroke. So that is why whenever we are seeing patients of acute MI in the emergency, we we had developed this program of acute primary angioplasty in these patients. But these days, we do the primary angioplasty only if we are able to do it with the full PPE kit, full N95 mask, and because it could be a mimicker of COVID-19. So that is the situation. And why did this happen? Because there is an effect on the platelet and red cell aggregation in these patients, leading to venous and arterial thromboembolic complications. So that is the impact of COVID-19 in these patients. These patients also present with pulmonary embolism. They become very breathless, and there is a disproportionately high incidence of venous thromboembolism and also arterial thrombosis in these patients who have COVID-19 infection. And the incidence of this has been found to be in the range of 35 to 40%, which is quite high. However, some people may say that it happens in critically ill patients in any case. Yes, it does, but the incidence otherwise is not so high. It is in the range of about 10 to 15%. So which means with this infection, the coagulation pathways or coagulopathies are much more enhanced and leading to more complications. So what is the mechanism? One of the factors which has been implicated is the ACE2 receptor. And we all know that this virus attacks the ACE2 receptor, leading to the incidence of vascular damage and risk of thrombosis in patients. So who are the patients who are more prone? Similarly, as we know for COVID, criticality, that elderly patients, overweight patients, hypertension, diabetes. So the more the comorbidities are, and those patients who have genetic predisposition to increase clotting, and those patients who are taking medications that increase the risk of clotting can be candidates for COVID-19 infection. And that is why we have also seen that in many patients who have been given the, even the antiviral drug has also been related to increased incidence of thrombosis in these patients. So anyone with a severe illness is the risk of developing clots in patients who are having COVID-19, and they present in various forms, as you already know, purpuric rashes, clots, and clogging of catheters, and then of course those who have extreme phenomena of embolism or acute myocardial infarction, they can even have sudden cardiac death. So this is the way it presents. It can present like acute MI, it can present like stroke, and of course pulmonary embolism. So it's basically hitting the patient in many possible ways when COVID infection actually gets in. So these clots actually are maybe sometimes the direct effect of SARS-CoV-2 infection on the endothelial cells that line the blood vessels, or it could be activation of ACE2 receptors, which are present in the body in various locations, leading to occurrence of clot formation in these patients. So the third mechanism, which is also has been proposed, is the effect of virus on the immune system, leading to release of inflammatory markers, leading to increased risk of coagulation through the various pathways which trigger the clumping of these platelets because of the inflammatory markers. So all these could be the various mechanisms, but certainly all these lead to one common effect, which is coagulation issues leading to venous and arterial thrombosis. So how do we treat these problems? Well, of course, these patients have to be put on anticoagulants like heparin or low molecular weight heparin, especially in those patients who are already hospitalized, or those patients who are on mechanical ventilation. They all have to receive these intravenous or low molecular weight heparin for prevention of thromboembolic complications. And the typical drug which we use is unfractionated heparin in these patients. Now, the second thing is about the use of antiplatelets. Antiplatelets in those patients where antiplatelets are already being given, it is being continued. We don't have to reduce the dose. In fact, maybe sometimes we have to enhance the dose or add a second antiplatelet. And those patients who come with stroke and MI, they are mimicking, they have to be typically given even the newer antiplatelets like ticagrelor and prasugrel, which are much, much more powerful than clopidogrel as we used to give it earlier. So the oral antiplatelet medication, although is not recommended to be given to just COVID-19 patients, only for high-risk patients or those patients who are presenting as the effect of thromboembolic complications. So in the end, I must say that there is a high rate of effect on the clotting, leading to serious effects like MI and stroke, and pulmonary embolism, leading to much more morbid and leading to increased mortality in these patients. So in these patients, anticoagulation is the treatment of choice, and preventing that is much more important. Now, that was one part of my presentation, but small few slides, 3-4 slides on how do we prevent the disease to attack us. And of course, because we are at the front line and we have to be careful. So as you can, you have to be careful of taking the history of these patients, because sometimes it has happened that the patient of MI has been brought to the cath lab, and then suddenly somebody took a history, whether you had fever, he said, yes, I have fever. So then that is too late. So we have to take the history of these patients. It is extremely important, and the history, you all know what we have to ask: fever, cough, breathlessness, etc. And of course, earlier it used to be travel history. Now I don't think it makes any sense to ask the travel history, because nobody is traveling. And then we have to wear surgical masks in hospital facilities, and those patients, in those situations where we need a level 2 or level 3 protection, is use of FFP2, FFP3 or N95 mask in situations where we are dealing with probable or suspected cases, and also managing confirmed cases. So this is the important thing, and use of PPE is recommended for situations where the procedure is being done or we are treating a patient who is already infected. So these are the measures. And for the family of the healthcare personnel, at home, people have to, it's better to use a homemade mask at home. It may not be necessary to use an N95 mask, and also do hand washing and cleaning up yourself much more rigorously than ever before. So that is the recommendation. These are the definition of patient risk status, based on which we have to decide as to what level of protection we should do. So there are 3 levels of protection which have been prescribed: level 1, level 2, and level 3. So in level 1, we have to use just the disposable surgical mask, disposable surgical gloves, uniform of the working uniform, and normal latex gloves. In level 2, it has to be a surgical cap also, a medical protection mask, which is N95 or FFP2, uniform, gown, and disposable surgical gloves and goggles. So that is level 2. And level 3 is disposable cap, medical protection mask FFP3, work uniform, gown, disposable surgical gloves, full face respiratory protective devices, or sometimes a powered air purifying respirator, which is now available, which can be used. And this is done, the level 3 is done where the aerosol generation is happening, where endotracheal intubation is being done in these patients where the confirmation of SARS-2 negativity has not been done. So in these patients, we have to do these things. And these are the various kind of masks. You must know which one mask, how much micron filter is there. And the last one you can see down is the powered air purifying respirator, which can be attached, and one can wear this while treating such sick patients. And this is the method of wearing and taking out the PPE, because most of us don't know how to use it also. So we have to know what is the sequence on which we have to use it, because if you don't do it properly, at the time of taking it off, you can give infection to yourself. So that is very important. So this is the donning and taking it off, doffing of the full, this equipment of PPE for any individual. So with this, I think I will stop here, and thank you very much for the kind attention. Thank you.
Yes, we will have a discussion at the end. Thank you. I'll ask now Professor Padma Awardee Dr. V. Mohan to talk about diabetes and COVID. What is the connection?
Thank you, sir. I'd like to thank Dr. Agarwal. It's the second time I'm having the honor of being on a webinar with him. I'd also like to thank Dr. Praveen Chandra for that very nice overview, because I think thrombosis is becoming very important in COVID. And of course, my good friend, Dr. Wangnu, with whom I have several sessions. Even recently, we had one session. So I'm going to get my slides. And I hope you can see the slides. Yes. So I'm going to make a short presentation on diabetes and COVID. What is the connection? Because we've been getting some recent recommendations from the Lancet and others about treatment. And so I'll take through a very brief presentation. The first question is, are people with diabetes more likely to get COVID-19? Now, this is a contentious issue, because there are people who say if people with diabetes can get all infections, why can't they get COVID-19? And that's a very valid point. But there's really been no evidence to show that if a person with diabetes sitting at home, a COVID finds this person like a drone, or develops an infection like, say, a urinary infection or something else, which comes even if you just sit at home, uncontrolled diabetes, you'll get it. So it's very unlikely. But then if your diabetes is uncontrolled, then you're more likely to get it. But the problem with people with diabetes is that worse outcomes occur. And the simplest example, laymanish example I give, is that COVID is like a fire. It just spreads. Now, if you have a matchbox with you and you have got a bad habit of opening the matchbox and then lighting the fire and then simply putting it on the ground, nothing will happen. It will die down, because it's very unlikely that that match will do anything. But if heaven forbid, if there's something flammable, inflammable there, there's petrol there or kerosene there or paper there or something else, then that same matchstick can just blow the whole house out of proportion. The whole house can be burned down. So diabetes is like that. Once you get it, it kind of spreads because of the COVID storm and other things, which I won't go into. So the question, are they more likely to develop severe forms of COVID or get severe outcomes? Yes, but again, there's a rider if the diabetes is uncontrolled, because I believe that if your diabetes is very well controlled, A1C below 7%, you have comorbid condition which are under good control, you're like anyone else, because the infection, your immunity level is almost at the same level as a general population. So if there's one take-home message from this for all people with diabetes is, control your diabetes well. You can't do anything about your age, you can't do anything about other things, but diabetes you can definitely look after. Because age and diabetes itself, it's a confounder, because the higher the age group, it's a non-modifiable risk factor, and therefore you get a lot of type 2 diabetes. So older people have to be even more careful. All the precautions that Dr. Praveen Chandra just now said should be taken meticulously with people with diabetes. What are the potential mechanisms by which diabetes can increase the risk? Older age I already mentioned, but also the comorbidities. If you have heart disease, hypertension, these are independent risk factors. If you have diabetes, old age, hypertension, heart disease, you're increasing your risk all the more. Yesterday, I was talking to one of my patients and doing telemedicine with them. On top of all this, the guy smokes also. So I said, you're really asking for trouble. I can't stop, doctor. And then I said, okay, then if you don't mind dying of COVID, then don't worry about it. But otherwise, we're really concerned about your family. He's only in his 50s. I said, you should, this is the time to change things. And then, of course, hyperglycemia itself is a growth medium. There are also immunological factors. We know that people with diabetes have higher affinity to and cellular binding, efficient virus entry. Once a virus gets in, it doesn't get cleared out. And then there's diminished T cell function, which is there. And then your innate immunity itself is reduced. And then there's an increased susceptibility to hyperinflammation. This is what I meant by the matchstick example. Once it comes in there, uncontrolled diabetes, a cytokine storm is released. And that's what leads to thrombosis and many other things that we are seeing people die of. Now, what is the evidence that severe and non-severe diabetes with COVID in patients with diabetes differ? These are about 6 or 7 studies. Dr. A.K. Singh, my colleague from Calcutta, put this together. And these are about 6 or 7 studies. And this is in this is in severe cases and non-severe cases. If you look at the diabetes prevalence, in the severe cases, it is like 3 times or 4 times higher than in the non-severe cases, just showing that it's a reverse causality. It's not a severe COVID, it's produced the diabetes, but although that also has now come up that COVID can produce stress hyperglycemia, COVID can produce direct beta cell injury and produce diabetes. I'll talk about that, but this is the other way around. Severe uncontrolled diabetes leading to severe COVID. Now, if you look at survivor, non-survivor, same story, all studies showing the same thing. You take survivors and non-survivors. It's not that the non-survivors, the prevalence of diabetes was higher. It's just that because of the uncontrolled diabetes, they died. So if you look at any death series, you'll find a lot of diabetes there. This morning, the health minister of Tamil Nadu put out all the causes of death and comorbidity. There's a very good article where he says 82% of all the deaths in Tamil Nadu, they've done an analysis, 82% had either diabetes or hypertension or COPD or something. Only 18% did not have comorbidities. So it's very clear that the low death rates in India, we are very lucky that in India the death rates are very low. But even within that low death rate, it is people with these uncontrolled comorbidities who seem to be getting it. This, of course, came out early from studies from Wuhan. If you look at the case fatality, 2.3%. With age, it goes up below 9%. There was no deaths, although later I think 1 or 2 were reported. But as you go up, say above 18 years, almost 80 years, almost 15% deaths. Look at diabetes, 7.3%. Now, these rates have been revised just yesterday by CDC. Now, the WHO said that about 3 to 4% of people die. CDC has today given a statement saying that only 0.2 to 0.3% of the infected cases died. So if you talk about 0.2 to 0.3% dying, this is overall, not India, overall. So 0.2 to 0.3%. And we still know that many are asymptomatic. So the actual death rates are very low. What we are seeing is the tip of the iceberg. What we're seeing here, after they die, we say, oh, they had diabetes, they had this, they had that. There are many who are asymptomatic and are going away. And this is one message you should tell people, don't get scared. Because every time you tell a person with diabetes and hypertension, we have 70 million people with diabetes in India and quite a few million in Tamil Nadu itself. There have been like 100 deaths in Tamil Nadu, of which about 50 people had diabetes. So I said 50 people die every hour and due to other causes, not due to COVID. I'm sure heart disease and other things kill much more people. So we shouldn't lose track of non-COVID causes. That is one of the things I would like to very strongly say. I'm not going to go into this. I think Dr. Praveen Chandra has already talked about this, the cytokine storm, which is actually responsible for not only pulmonary, but also cardiac, acute renal injuries, and the thrombosis and so on. So the next question is, are people with type 1 diabetes also more prone or carry worse prognosis? Just about a few weeks ago, when I was with Dr. Agarwal on another webinar on this, I gave this answer, saying that there's very little data to support this. I haven't changed my slide, but I think now I have changed it. A very recent study from UK, just 4 or 5 days ago, 1 week ago exactly, which showed that the death rates are higher in type 1 diabetic patients than type 2. I find this very difficult to believe because these are young people. The people are 20 years old and 30 years old. And Germany didn't see this, US didn't see this, and Italy didn't see it, Spain didn't see it, in India we haven't seen it. So far, one of my type 1s has developed, and it's so rare. And one of my patients developed, he recovered fine without any problem. But in the UK, they're saying that if you age adjust, gender adjust, and then look at it, the death rates are actually higher in patients with type 1 than in type 2. And it's a very large study. It's a whole nationwide study in the UK. So Every day we are learning new things about COVID. Every time we think we know something, we really don't know anything. So there's a lot of unknowns as far as COVID is concerned. So the problem is that treat every diabetic patient as if they carry worse prognosis. That will be my advice. What should people with diabetes do to prevent COVID-19? First of all, let's tell patients not to panic. I've had many patients who have called me and said, Doc, I've written my will. That's my end. You're not going to see me again. I said, of course, I'm going to see you. I'm going to see you, and you will see my child also, and you'll probably see my grandson also. So don't worry about it. That's the first thing to tell them, because the moment they read in the papers, above 60, diabetes, this, death, how many people have died? Like 40 people died in Tamil Nadu. What? Let's not, even go there, So nothing is going to happen. You practice the principles even more strongly because you have diabetes. Social distancing, physical distancing, hand washing, wearing the mask. And we saw all those masks which Dr. Praveen Chandra showed. Good respiratory etiquette. These are very, very, very important. But these are very general. So what extra precautions should people with diabetes take? Control diabetes well. You can say that 100 times. Check sugars often to ensure good control. We found two things. There are many patients who have started checking many more. And in a study which I've just done, it's under publication. It's just been accepted publication in International Journal. We contacted 2,500 of our patients and asked them various things, what they did during lockdown. Surprise, surprise. Actually, they did better. Many of them, their A1C actually came down from 8.2 mean to 7.7. That's because there's no stress. They were eating better. They were sleeping better. They didn't have the tension of work. There's no pollution. They didn't have deadlines to meet. They're working from home. So many of them did better. I'm sure Dr. Praveen Chandra and Dr. Agarwal will say that maybe the heart attacks also came down. That's what I'm hearing all the while. So there are certain good things also which have happened if you look after well. On the other hand, if you neglect everything, then you're asking for trouble, like my friend who was smoking the other day. So eating healthy includes more vegetables, fruit, and protein. These are the three things which are going to build immunity. No doubt about it. That if you take more B12, more iron, more fruit with antioxidants, vitamin C, zinc, and protein, this is going to build your muscle. This is going to build your immunity, and you're going to get stronger, and therefore you can survive. We showed about 2 years ago in the PURE study, Salim Yusuf's PURE study, that the grip strength, just the grip strength, will determine how long you live. Those are the poor grip strength, frail people. They tend to die. So such a simple thing like a dynamometer, grip dynamometer will tell you about your survival. So that's why the protein and the exercise comes in. Of course, pranayama, Dr. Agarwal is an expert in that. Last time we spent a lot of time talking about it. Not only it improves lung function, which is very important, oxygenation, it decreases stress. And stress and anxiety, depression are one of the big things to reduce your immunity and to make you at higher risk. So I would advocate everybody doing pranayama, and if you can do the rest of the yoga and meditation, that is also great. So good nutrition practice will include eating well, eating slowly, eat on time. That's very important. I think that's why my patients improved. Now they're all able to eat on time. Otherwise their lunch was at 2:30, 3, 4. Now 1 o'clock, they're all at home and they're able to have their lunch. Eating right. They were able to get fruits, vegetables. I thought that the grocery stores were all closed, but the majority of them said, well, we stocked up, we got it, we were able to do it. And then having a more complete balanced nutrition, because so much of things they're hearing on television and social media that they've actually improved their diet. Now, there are certain things we cannot change when you talk about immune function, things like early life events, genetics, gender, age, hormonal status. These things we cannot, or exposure to pathogen, these we cannot change. But look at these, the nutrient status, diet, gut flora, obesity, smoking. Again, smoking comes up here. Alcohol, smoking. Now, one of the reasons why people probably improved was they couldn't get alcohol. You saw the queues after, in the Tasmak shops and others after they opened. There was no alcohol, no smoking. So that's one of the reasons why probably people improved. One of the reasons why probably the diabetes and heart disease and all that came down during this time. Exercise was problem during lockdown. It is an issue. Many people could not exercise at home. Even not everybody has a treadmill and so on. But it is one way to improve your nutrition. And of course, reducing your stress. Vaccination. We cannot vaccinate against COVID yet, but we can still vaccinate against pneumococcal, against influenza, and hope that some of that spills over. At least we get a secondary infection. Mixed infections are being reported. H1N1 and COVID, both occurring together. So those kind of things can be avoided. Can all anti-diabetic drugs be continued? if there are no or mild symptoms, many 80%, today's Tamil Nadu statistics says 86% of patients are asymptomatic. If you're asymptomatic, so what? You just continue what you're doing. Life goes on as usual. But if you have severe COVID, you have to be admitted to hospital. Stop many drugs. Metformin probably should be stopped. SGLT2 definitely to be stopped. And then to prevent dehydration. Sugars are high, start insulin. Okay, because insulin has some anti-inflammatory effects. Quickly running through the slides. Metformin, the jury is divided. It has anti-proliferative immunomodulatory effects, but then there's a risk of lactic acidosis and mild dehydration. And it has decreased the role in pulmonary pneumonia mortality has been shown. And therefore, we don't know. But if the diabetes is mild, continue metformin, safe drug. Otherwise, it's okay. TZDs, I'm not a big fan of TZDs. I think we should actually stop TZDs because there is, it is known to increase ACE2 expression. It will definitely increase fluid overload. It will increase your weight. And there are other side effects associated with this. So this is a very good drug to take. GLP-1, there has been some evidence that it increases the ACE2 expression in the lungs. We don't know, but these two probably can better be stopped. DPP-4 inhibitors, there is actually some evidence that it may be helpful. There are a couple of reports which have been shown. In MERS, for example, reduced viral entry has been shown. And many people are saying that perhaps, again, there are some people who say, no, it's actually bad during this and so on. Okay, but there are some people who believe it can decrease the risk of COVID-19. I don't know, but it's a very simple, gentle drug. If you're taking it, sugar is controlled, you take it. SGLT2, I said, in severe cases, stop. Euglycemic ketosis, risk of dehydration. Sulfonylureas insulin, no harm in taking it, but the dose will have to be adjusted. So in hospitalized patients, especially in ICU, better to be on insulin. Not better, you have to be on insulin. IV insulin infusion, frequent blood glucose monitoring every hour or two. Other methods of giving insulin, multiple short-acting insulin, insulin analogs, especially in ketoacidosis, single basal insulin, insulin pump, and so on have also been used in advanced centers. Therapeutic goals between 70 to 180. You can even raise that to 110, 120 and take that up to 200 if you like in sick patients. These are in normal patients. A1C below 7 we should aim for. This new thing about time in range, it's not range, it's in range. TIR, this is after doing ambulatory glucose profile. So if you do the continuous glucose monitoring, 70% of the day you should be under control. Avoid hypoglycemia. We don't want you to go into hypoglycemia and trigger an arrhythmia or something. And that's where the SMBG and CGM will come into effect. We found that the use of SMBG actually went up during the lockdown period. From 28% of people who were testing, it went up to 50%. 50% are still not testing, but at least that was good. Insulin resistance has been recently reported. So some centers are saying that they need tremendous insulin requirement. In the new COVID cases admitted, they need 200 units, 300 units, 400 units. What is the mechanism? We don't know. Something it seems to do to block the insulin. Increase in DKA has been reported from ketoacidosis has been reported in some centers. Can COVID precipitate new onset diabetes? Whenever we've had an emergency, whether it's a tsunami, whether it is an earthquake, whether it's something, we have seen diabetes go up. Why? Stress, anxiety, depression, because that's one of the counter-regulatory hormones keep going up. Your cortisol goes up, your growth hormone goes up, everything goes up, it blocks your insulin. So that is one. Apart from that, irregular lifestyle, unhealthy diet, some people said we couldn't get fruits, we couldn't get vegetables, physical exercise went down in some people. So it can precipitate in a pre-diabetic suddenly. And stress, of course, very important factor. Direct viral damage to pancreatic beta cells has been shown in some experimental models. In humans, few case reports are coming in. We'll have to wait until we really know that. Is there a COVID-19 diabetes, new onset diabetes? Possible, we don't know. So these are my summary of recommendations actually adapted from a Lancet article, slightly modified. In outpatient diabetes care, sensitization of patients regarding better metabolic control. I would like to go on top of a mountain and take a loudspeaker and say, control diabetes well, control diabetes well. That's the only thing we can do. We cannot do anything else. And I think we cannot shout enough. We must keep on doing this. Optimization of current therapies. If you're not under good control, this is the time, is an excuse or a motivation for you to control, not to discontinue treatment. Lot of diabetic patients discontinue treatment. They read all about alternative treatment, this one, that one, reversal of diabetes. All quacks go on social media and tell them in one day I can cure your diabetes, and they discontinue treatment. This is not a time to discontinue treatment. Better attention to diet, exercise, stress reduction, yoga, meditation, pranayama, again and again, back to that. Use of telemedicine, which has been there. Now it's slowly going down. We start opening our clinics. People don't like that all that much. It's good when nothing else is available, but they want that personal touch. Inpatient diabetes care, plasma glucose monitoring, maintaining ketones, pH, fluid balance, insulin dose adjustment, watch for and treat complications, including thrombosis. You should be looking out for these rare things. So I'm going to stop here. I just wanted to tell you that for those who want to learn more about diabetes and COVID, I made a lot of videos, also a few videos about immunity, vitamin D, each thing that people ask about, vitamin C, all these things I made short videos. They are available on YouTube. And if you just put Dr. V. Mohan, you'll get them. It's free. And so anybody who's interested to learn more about it can do that. So I'm going to stop here and we will hand over to Dr. K.K. Agarwal. Thank you, sir.
Thank you, Dr. Mohan, for a wonderful overview of the link between diabetes and COVID. We will have a discussion at the end. Let me now come back to Dr. Subhash Wangno, who is going to talk about an important subject, and that's doctors' health. Doctors dying of heart attack, diabetes, and cancer in COVID era. I gave an introduction that many doctors have died. One of them had a silent death. In fact, the first death of a doctor who was an Italian, that was in early March, the team which came from Italy, they were staying in Jaipur. He was discharged on 14th day, and within a week, while he was recovering, he suddenly died of an acute MI. So let's listen to Dr. Wangno.
Thank you, Dr. Agarwal. And first of all, I must thank my colleague, Dr. Praveen Chandra and Dr. V. Mohan for beautifully elucidating the various connection between diabetes and COVID-19, and Dr. Chandra how beautifully explained how thrombosis occurs in patients who suffer from COVID-19. I think Dr. Mohan has shown beautifully the connection between the COVID-19 and the severity of the infection and a higher mortality rate in persons who have associated comorbidities. And it has been shown and confirmed that patients with any comorbidity had a poor clinical outcomes than those without. The study from the first of its study from Wuhan, China, revealed that chronic obstructive pulmonary disease, diabetes, hypertension, cardiovascular disease, malignancy like cancers were risk factors of reaching the composite endpoints of admission to an intensive care unit, invasive ventilation, or the death. And Dr. Mohan also told about the increase, the most important comorbidity in the non-survivor from the ICU from the Wuhan was the diabetes, hypertension, heart disease, chronic obstructive airway disease, and the cancer. We all know that data points to an increase in the mortality in COVID-19 with the known hypertension, diabetes, CVD, COPD, and cancer. So it is our duty that a special attention is definitely required in patients with COVID-19 with associated comorbidities, including hypertension, diabetes, and established CVD. You know, we have two very recent good articles from our own colleague, Dr. Udesh Kumar Singh and Anup Mishra. They are given the outcomes in the hypertensive cohort and the controversies with the RAS blockade, which they have beautifully explained that RAS blockade can be safely continued even in diabetic patients. Now, why COVID-19 is a double challenge for people with diabetes? Dr. Mohan clearly explained that uncontrolled diabetes is an important determinant for the severity of the infection. It is not that they are prone to develop COVID. The only thing, if the uncontrolled diabetic develop infection, he gets more severe infection and the fatality rate is more high. primarily, basically because of the disturbed immune function. It is not only the innate response, even the adaptive response to the immune response to the immune system is lost. Innate, the inherent immune response when the virus attacks the human cell, the human body, and the adaptive response when you are capable of fighting the disease when it has entered the cell and is showing the symptomatology. So patients with diabetes need intensive attention to reduce the risk of fatalities, and they should follow the general prevention advice to avoid infection with the COVID-19. Analysis of Italian Medical Council has shown that 16.5% of patients who died from COVID-19, 909 patients, the 16.5% of patients were suffering from cancer. So that becomes an important comorbid condition. And again, a pooled meta-analysis has shown the risk of contracting COVID-19 was higher among cancer patients and survivors than the general population, again, because they are immunocompromised. Now, coming to the basic and important question Dr. K.K. Agarwal has told me to discuss, the most difficult topic. We, as the healthcare workers, are on the front lines of the global effort to care for the patients with COVID-19. While putting themselves at risk for the infection, more than 1,000 healthcare workers have already died. A very sorry figure. Given the worst outcome seen in patients with comorbidities, our healthcare workforce with the underlying disease, whether they are suffering from diabetes, whether they are suffering from heart disease, whether they have associated hypertension, or they are suffering from lung disease or the chronic obstructive pulmonary disease, or they had a previous cancer which they have survived, are at increased risk of contracting the infection and probably suffering from the worst outcome. I like the word of Dr. K.K. Agarwal, the charity begins at home. We are also human beings. The doctors can also suffer with the various disease spectrum. A common notion among the mind of the patients, oh, you're a doctor, you can save yourself. How come you have become sick? We can't believe it. We are also human beings. We can also become sick at any time as all of you as patients. We are not different from you. The only thing, the added quality we are having to treat the sick. And in fact, when the doctor becomes sick, it becomes more difficult for him to get treatment, for reasons, obviously. Now, there are several reports of deaths due to COVID-19 healthcare workers we know from across the whole globe who had an underlying illness. And Dr. K.K. Agarwal told you about the recent, very sorry that we lost our senior AIIMS doctor, Dr. J.N. Pandey, because of COVID-19. So I told you, we as a healthcare worker are as precious as the patients they are currently being treated. We have to have measures in place to protect the vulnerable members of our healthcare workforce from this infection so that they can continue caring for patients and safeguard themselves as well. If we are not well, if we are sick, then there will be a big problem for the patient, how they are going to get the dedicated healthcare services from the dedicated healthcare team. Though there are some suggestions what we can do. These are some of the suggestions, observations, recommendations. Every day is a new experience to us. Every day we have some new recommendation. Every day we have a new figure. How many people, every day we know something that this happened. Ideally, what should be that we should not deploy the younger, what you call the frontline healthcare workers who have recently become pregnant or are having underlying diseases which makes them immunocompromised providers in COVID-19 wards. We never ask the healthcare providers that whether you had history of diabetes, whether you are suffering from hypertension, whether you had some lung problem. So it is obvious that we must also come out, and specifically when you are being posted into the COVID-19 ward, you should always tell that you have to take your health, come out openly that I'm a diabetic patient, I had a lung problem, I had suffered this problem, so that proper care can be taken by you before we take care of the patients. Like a very good, everybody is taking, the government agencies are telling that shift the healthcare providers who are above the age of 60 and those who had comorbid condition, which I already told you, to be in direct care of the patient with the COVID-19. Older patient, Dr. Mohan told, Dr. K. Agarwal told that they're also vulnerable healthcare workers and they should be given a chance to treat at a safer distance. These healthcare workers who are vulnerable may be shifted to phone or virtual encounters. We can take help of our senior consultant through virtual telephoning call, the video consultation to the juniors who can take care of the frontline workers to treat the COVID-19 patients, particularly in the critical care wards. Virtual rounds with the senior physicians is very important and could allow the social distancing and ensure continued guidance of our younger colleagues. We have to follow that. We have to do that, whatever may come. Senior physicians could leverage their skills to train others on some of the procedures, such as intubation, management of severe respiratory failure. Like we have a critical care team, which is led by Dr. Chawla, Dr. Kanwar Dej Bansal, Dr. Rosha, who have been training the juniors over the last 203 months, how to do intubation, how to manage the acute respiratory failure. So they are doing the good job, and they are just behind the curtain to help them. Provision of the adequate amount of PPEs, Dr. Chandra told, Dr. Mohan told, which is a huge, huge task, and the government has to come up with this provision of adequate amount of PPEs to protect the frontline workforce because of the sheer number of patients in our country and the number of healthcare providers which has been basically trained and which has been basically treating the patient at present. Apart from that, our psychiatrists should be as the backbone of provision of the psychosocial support for the healthcare profession. It is very important. I have seen many of my colleagues just with the fear of acquiring COVID-19 had not been attending their duties for many months because of their vulnerable population. This psychological support should be tremendous at this time. And what should, as a clinician, as a specialist, we should do? We should protect ourselves. We should minimize our chance for exposure. We should ensure policies and practices that are in place to minimize exposure to the respiratory pathogens. Measures should be implemented before patient's arrival, upon arrival, and throughout the duration of the patient's time in the healthcare setting. We should continue our treatment. Often the doctors are the most vulnerable population, which they don't take medicines at time because of their busy schedule. If the diabetes on multiple doses of insulin, because of his work schedule, he will forget to take one shot of the insulin, which is really very harmful. You have to think that you are also a patient. You have to take the medicines as you guide to the patient. Charity begins at home, I again tell you. So you have to treat as the way you are treating patients. Follow standard precautions and communication. Discuss your risk with your treating doctor. Don't hide it. Engineering control is the best way. Consider designing and installing engineering controls to reduce or eliminate exposure. And Dr. K.K. Agarwal told the negative pressure right from at the entry, when the patient enters into the triage, should be effectively adhered to. Implement environmental infection control measures as laid down by the infection control committee of your hospital, and manage the visitor access and movement has to be done very meticulously. Like our hospital, right from the various door entry, they have been having the thermal scanners, They check every patient before they come in contact with the doctor. And most of the doctors nowadays has switched to the e-consult, video consult to limit exposure to the patient, particularly those specialties where they don't require much of the physical contact or the examination, like endocrinology and so many other specialties. So I have been doing a lot of video consult and everything. With that, my simple, I wish and pray that all our healthcare community should take care of themselves before they take care of the patient. Our life is as precious as the life of our patients. We should take care of ourselves. I'm very sorry to say that even in our hospital, I have seen many of my colleagues falling COVID positive. They have become COVID positive over the last 1 month. The numbers are increasing. Is a sort of a very scary figure, and people are really afraid. And we should come out whatever the precautions I have told you. Thank you very much.
Thank you, Dr. Wangno, for a wonderful presentation. And charity begins at home. We all doctors need to do something. Can you take your sharing out so that we can discuss it out now, Dr.
Right.
Wangno? Just close the sharing.
Just close it. Anuja?
Yes. Thank you. I'll start with an important discussion in a sense that we end up with some take-home messages. First of all, I'd like to have Dr. Mohan, and he very clearly said that diabetes, whether we are doctors or non-doctors, if we keep our diabetes under control, we need not worry. Two, the risk is not that significant. The risk, if the risk of COVID has come, it also had simultaneously reduced the risk of MI, stroke, diarrhea, jaundice, food poisoning, illnesses, pollution, many other illnesses. Even tuberculosis, MDR tuberculosis is likely to go because you are likely to pick up in the disguise of a COVID-19 patient. One thing I want to add is, because when we talk about pranayam, equally important is because when you get sick, the pulmonologist will tell you to lie on the abdomen, and they say that lie on the side. So what about telling all our diabetic patients to start practicing it? In any way, it is good. It will take away their snoring. So if we put down as that every diabetic and hypertensive and high-risk patient should start lying on the abdomen.
Good point, sir. Very good point.
So that is one thing. And the second thing is, you said that UK type 1 diabetic complications were higher. It's not expected. It is not unexpected. Yeah. The mortality in UK is double the mortality in US. Yes, yes. And US mortality is double the mortality of Asia. Yeah. And amongst Asian, India has the highest mortality. The lowest mortality is in Singapore and in Hong Kong, which is less than 1%. UK, we are seeing hyperimmune inflammation much more than anywhere else. So we are seeing Kawasaki, we are seeing multisystem. In children, we are seeing multisystem inflammatory disease. Maybe the type 1 are the one who is mixing up with hyperimmune inflammation. Yep. Maybe the answer, because this complication we are not seeing in other than Europe.
There's one more point, sir, that if you look at the obesity rates, because reading that paper, see, when we talk of our type 1s, they are thin people. Only type 2 diabetics are obese, and even there we don't have that much obesity as what they have. Their type 1 diabetics are obese. So they already have snoring, they have COPD, not COPD, they have sleep apnea, and all these things they already have. So they are a very high-risk population compared to us. Why the difference with Germany, I'm not able to explain. Whether Germans' BMI is different, type 1 from... But this man, we were on a call where we had people from Germany, US, Israel, and only these UK people were talking about it. And all the others said, we are all your neighboring countries and we are not seeing type 1s dying. We're seeing type 2s dying, but not type 1. What is peculiar in UK, and that's a government system, NHS, where everything is given free. They have no shortage of insulin. They have no shortage of strips. They have nothing. So it seems to be an outlier, and we'll have to study why it is so. But I looked at the BMI. Their BMI is 30 and 32 and all that for type 1. Very unusual. I don't have type 1s with 30, 32, that many at all. So maybe obesity and other comorbidities, maybe they're having hypertension or something else.
Maybe Dr. Chandra, I want to ask you one thing is that in this scenario, we are going back to the era of thrombolysis, And then we say, if you want to go for a PCI, go for only the infarct-related artery, leave the second artery for some time. And we also know that even in spite of empty platelets, a person still can get thrombotic phenomena, because thrombotic phenomena is not being prevented by a single drug. So do you feel in this era, for a year, people should go back to dual antiplatelet therapy as a prevention, and specifically adding ticagrelor?
You're muted. You're muted, Dr. Praveen Chandra. Unmute, please.
You are asymptomatic, become symptomatic, and then.
So basically, the point about treating acute MI, this is a very important point you have raised, that whether we do primary angioplasty or thrombolysis. So it is recommended that if the patient has come with acute MI and you can do the primary angioplasty with all the PPE kit, with all the protection within the first 60 to 90 minutes, it's okay. You can do that. But if not, then the treatment of choice is thrombolytic therapy. It has already been shown to be effective. So there should be no hesitation in doing that. And the only thing is that you should not, it's not recommended to do the primary angioplasty without protection and without any, further follow-up of cleaning the lab, etc. Because very recently, just 1 week back, there was a pacemaker implantation which was done in Lucknow in the PGI, and the patient came with a complete heart block. Temporary pacing was done in one hospital. Patient was shifted, and before they could do the COVID, they put the pacemaker, and then the COVID turned out to be positive. So then it was a huge chaos in the hospital. They had to close off the cath lab. So that is why we have to take these precautions, certainly for us and for our fellow workers who are working in the cath lab, who are working in the hospital. So this is very, very important.
So Dr. Wangno, I'm currently the president of CIMAO, which is Confederation of Medical Association of Asia and Oceania. We have 19 Asian countries, and in one of our consensus statement we have got, and we have is called contact time. When we say contact time is a contact time or less than 30 minutes, you are not at risk. And our recommendation says is that if you are wearing a mask, patient is also wearing a mask. In the room, if you have an air purifier with 12 exchanges per hour, and even if you exposed to a patient with COVID-19, you did not worry. And that will answer Dr. Praveen Chandra, that cath lab, if you happens to have a patient with COVID-19, there should not have been a chaos, and the lab should have continued as it normal. If we take precautions like masking everybody and either AII room, which will not happen in a cath lab, so putting in an air purifier with 12 exchanges per hour.
Sir, you are right, but the practicality is that every doctor, suppose in the hospital, there are so many chambers, it is not possible for the hospital to have separate air purifier in each and every chamber. Either we as a healthcare worker should buy air purifier in our clinic, what we are seeing in our OPD, so that we can protect ourselves, like I have been using air purifier in my clinic for last 1 or 2 years, even before the COVID came. So because we know that the contact during the contact time, and we usually don't give more than 10 to 15 patient, and the patient is wearing mask, the patient has already been screened, and then we are keeping a distance. So I think when we are taking care, you're right, the recommendation that the healthcare workers can protect themselves easily if all the facilities are given to them at their disposal.
So Dr. Mohan, when we talk about transmission, it is basically when we talk face-to-face. So therefore, we recommend that if it is a table, if a doctor is sitting here, I make my patient sit here and not face-to-face. And if my contact time is less than 10 minutes, I'm okay. And if he's wearing a mask, it's okay. Number two is if we are sitting face-to-face, then the doctor has to be slightly up so that their air exchanges do not happen. And we take a double protection of a masking along with a face shielding, then you protect much more with that. And then we are also talking about not to shout.
Yeah.
Because if you shout, there are two types of words, aspirated sounds and non-aspirated sounds. Say ka is produced from the mouth, kha is produced from the abdomen, ga from the mouth and gha from the abdomen. The sound gha will produce a virus which will go up to 3 to 6 feet. So therefore, we tell all our patients, speak slow. In a clinic, nobody will shout. They will speak softly, wear a mask. And if you want to have a junior who is assisting you, prefer a junior who is a female, young doctor, because that's what Italy did. They put all their young lady doctor less than 40 years in the front line, and nobody got infected because chances of mortality or getting severe disease in women is very, very, very low.
Sir, I'm doing the same practice. I have a junior who has been assisting me. She's less than 40 and we are keeping a distance. She's doing all the job. I'm just giving the final dictation. And that is why we are having the shield, double protection mask, caps and everything. So what I am following, being a senior citizen above 65, I have to care about my health also.
I think I entirely agree with you, sir. I think all the practical points you're saying is very good. The another point in a lighter vein about the shouting, if you shout, your immunity is also going to go down because your mental peace is disturbed. Your immunity is also going to go down. So remaining calm is also going to help that also. The other place where where we feel very careful when we open up our spiritual centers is bhajan singing. Because when you sing a bhajan or you sing anything for that matter, unless there's quite a distance, it's very difficult in a spiritual center to keep people very far off. That is why in our I'm part of the Satisai organization, Baba's organization, we have not opened yet. We have said, no, we are not good. Because we can't but sing bhajans once you join it. And when you sing a bhajan, you're singing loud and it's going to carry quite a bit. And if you are infected, most of them are asymptomatic. We don't want this to become another clusters. So I think these kind of basic precautions, if we follow, to a large extent, I think it will die down in the next 2-3 months. Now there's going to be a little increase after the lockdown, but after that, I think it will flatten out and it will settle. That's what we saw in the US. We now thought so quickly it will flatten in the US. And other countries like Italy and Spain, very quickly it flattened. UK is an exception in every way. Right from the Prime Minister, they got it. I mean, it's an exception in every way. So, but I don't know. We have to be careful. India has to be careful. One thing we are lucky is that the death rates are still not as bad as reported in the
So at this point, I would like to take opinion of all three of you that our mortality rate is less than 3%, though it is the highest amongst the Asia. The mortality rate in US is 6 to 7% and in Europe is 10 to 12%. I don't think so. It's the lockdown, and I don't think so because if it was the best of the services, America and UK would have been better because we still can't say that we have best of the ventilator care available.
Not at all.
And even if that was responsible, that could have changed the mortality only by 0.3% because only 2% people are serious and critical. So what savings the Indian? Is it what? I mean, I need to
immunity, sir. I think we basically, we have so much of other infections that we are exposed to. That is why if you see the South Asians living in UK, they're doing very badly. But they've been there a generation and two away. And so their basic innate immunity is much lower. And we, with our increased diabetes, with increased insulin resistance, with a high carbohydrate load, which produces chronic inflammation, we would have been a very high risk population actually. The fact that we have still not got it in spite of, even during lockdown, sir, we are saying lockdown. Okay, rich man, he has a house, he has a flat, he is staying in a so. What about the poor people? Majority of people are poor. They are what? Lockdown made it worse. They are all staying together during lockdown. At least they would have gone to work. A construction worker going to work is not going to get COVID. You sit in the home and your neighbor has it in a slum. That is why in Dharavi in Mumbai, where there was more congestion, more happened. The places where they are spread out, it didn't happen. Among the rich people, it did not occur that much. It disproportionately affected the poor. So I think it has a lot to do with our innate immunity, which thanks to BCG or anything else, we have developed it to some extent. And that has kind of protected us. So this 3% in India also, it is not correct, sir. It is actually much, much, much lower. We have thousands and thousands of cases which are undiagnosed. How many tests are we doing?
We are not saying, we are saying 3% of symptomatic cases. These are all symptomatic cases. If we take some asymptomatic cases into consideration, the mortality will go down to less than 0.5%.
Dr. Agarwal, my one of the comment is that are we having a different kind of a strain? The different strains are doing rounds across the whole globe. The same strain is not affecting the different parts of the globe. Is there any evidence the strain which started from the Wuhan, China, started mutating when it went to the US or Italy or to India? Is there any proof, evidence?
We don't have any proof. There are multiple strains which are roaming around in Delhi, in India. 3 strains definitely are roaming around. One China, which went into Italy, and that strain is there. US strain is there in India, the one with the US. But we still don't know that can explain the whole thing, because our strain has to be separate to. There is nothing like an Asian strain, which is causing a less harmful in the Asia. Dr. Praveen.
Yeah. I mean, as been discussed by Dr. Wangnu and Dr. Mohan about the various possibilities. I mean, nobody knows what is the reason, but all these possibilities look very plausible at times. But if you go a little bit deeper, like for example, Dr. Mohan was mentioning about the cross immunity and our general level of immunity. But let me tell you, in general, we get infection much more than others. We get viral encephalitis, we get viral pneumonias, everything is happening in the same numbers. So why we are not having this? Maybe that the disease has not struck us early enough. Maybe we are, we started our protection little early. So that may be one reason, I think. And the second is that, the variant which has come to us maybe not, very potent, or mutation has already happened. So those are the things. But, I was just, initially I was also thinking that probably we are having cross immunity, and we are having the level of immunity is so good, but that is not reflecting in our previous records of infection levels in India.
3 quick questions, and before I end, I want Dr. Praveen Chandra to again, because he didn't answer that question. Ticagrelor, should we add 2 antiplatelets at this moment? All those patients who are in 1 antiplatelet, should we make them 2 antiplatelets for some time? Or if they end up into a disease, should we shift to 2 antiplatelets?
Okay. So that's a good question. So those patients who are already receiving 2 antiplatelets for their post-intervention status or post-bypass status or post-MI status, they should continue the same. There is no need to stop it. But adding a second antiplatelet without any other indication just because of COVID is not recommended. If they are in the hospital, they are bedridden, then we have to add low molecular weight heparin or intravenous heparin, depending upon the situation.
I want to ask one question to Dr. Wangnu, and that is that in the US, the Black population is more at risk. They are dying of COVID infection. And we know that ACE inhibitors don't work in them in hypertension. Is there a link? I mean, the Black population of US is dying much more than the white population. And we also know that the Black population, ACE inhibitors, we don't give them for hypertension. So ACE inhibitor, ACE receptors, Black population, is there a link?
You're muted, Subhash, you're muted.
Anybody can answer this, yes.
There are other factors also, sir, before Subhash comes in. Probably, again, obesity is a big factor with them. We don't know about their immune status. And of course, it could be uncontrolled hypertension. We know that the Blacks have a lot of uncontrolled hypertension. The hypertension is different. So there could be a link, sir. Subhash, want to answer that?
Because it is right, because of the obesity, they are more prone to get lot of what you call the highly metabolic active fat, which releases a lot of pro-inflammatory mediators, which again is a cause of the increase in the severity of the infection, and particularly in diabetics also, because of obesity, they are more prone to get infection, though they are not being treated with the ACE, but still we know that there's an increased expression of the ACE2 receptors in more so in obese type 2 diabetic patients. That might be one of the reasons. I don't know really.
We could also think of the socioeconomic factors, the poverty, they're living together, other factors. We talked about our slums. That is, it's a reflection of socioeconomic status. Therefore, their immunity may not be that great.
Maybe it's the same thing is in Singapore. They are also getting in their migrant population. So before I hand over to Narendra Choksi for final comments and Thanksgiving, I need to add one thing is that this COVID has taught us a lot of spirituality. It has taught us aparigraha. There is a thing in parigraha is accumulating things. And now this virus is telling us practice aparigraha. That means you should not have a lot of furniture in your room, in your clinic. You should not have a lot of clothes in your wardrobes. So he is telling us earn less, live in the house, spend more time with your family, take care of your elders, and take care of all your atithis. Make them sit in a high pedestal. And he says, I will not affect you. Let me live outside. I will not trouble you. And even if I enter your body, I would like that you start controlling your diabetes and blood pressure and other things so that I can come silently, stay there for 14 days with you and pass out. Don't force me to stay in your body for 28 days and in a ventilator situation. I don't like it. So therefore, control your diabetes, heart disease, and blood pressure. That's a message I received last night from him when I was with dreams with him. So he said, kindly pass on a message. I don't like people who keep their sugar and diabetes and blood pressure uncontrolled. All yours, Narendra Choksi.
Thank you, sir. So we are now towards concluding this wonderful program. I must say this was an exciting program which has enabled us to gain from the wisdom and expertise of speakers and moderators. I take this opportunity to thank Dr. K.K. Agrawal, Dr. Praveen Chandra, Dr. Mohan, and Dr. S.K. Wanglo for their great contribution in making this program possible and successful. I am thankful to all the participants who have taken time out of their busy schedules to attend this program. I thank all of you for making this event a success, and I sincerely hope your support will remain with Torrent in times to come. Thank you and goodbye.
Thank you.
Thank you.
Thank
Stay safe, everyone.
Thank you.
you. Bye-bye.